The next chapter is going to be for a change EC. For a change, the next chapter is going to be EC, where you are going to calculate various waves. So now, having understood the lead system, having understood various waveforms in my ECG, I want to know each one of my waveforms is normal or abnormal. Whether my P wave is normal or abnormal. If it is abnormal, why it is abnormal? If a QRS is normal or abnormal. If it is abnormal, why it is abnormal? Like that. T wave is normal or abnormal. For that, I must know whether what is the normal amplitude and the duration of each one of these waves. When the waves are abnormal, what is the clinical significance? For that, you have to understand the ECG paper first. So, ECG paper only helps you to calculate each one of these waveforms amplitude and duration. So, our ECG paper recorded by the ECG machine has got small squares and big squares. There are small squares and big squares. Usually, horizontally we measure time and vertically we measure the amplitude. Each one of your waveforms will have the amplitude and duration. So, amplitude has to be normal, duration has to be normal. So, for that I have to measure what is the duration of the P wave, what is the amplitude of the P wave, what is the duration of QRS complex, what is the amplitude of the QRS complex. So, measure amplitude vertically, measure duration horizontally. For that, the ECG is recorded at the speed of 25 millimeters per second. Normal ECG speed is 25 millimeters per second. And it is normally the ECG is recorded in 1 millivolt standardization. So, in any ECG, before you interpret an ECG, you have to look at this vertical bar which is being recorded. In many ECG machines, it may be recorded before each one of these leads, or they can give it in the bottom of the ECG paper or in the side of the ECG paper and say in which standardization they are recording and which speed they are recording. Without making sure this standardization and speed, you are not supposed to interpret an ECG. Very, very important. You have to make sure the ECG is recorded 1 millivolt standardization. 1 millivolt standardization is nothing but this vertical bar will have 10 small squares. This vertical bar will have 10 small squares. Each one of your big square will have 5 small squares horizontally and 5 small squares vertically. Each one of your big squares will have 5 squares horizontally, 5 squares vertically, and your 1 millivolt standardization should include either 10 small squares or 2 big squares. So, this is your 1 millivolt standardization and the ECG speed of recording is 25 millimeters per second. Only then whatever I am going to say subsequently is going to be correct. Only when this ECG is recorded in this way, whatever I am going to say is going to be correct. Whether you see ECG to diagnose myocardial infarctions, ventricular hypertrophy, chamber enlargement, at least see ECG to check your eyesight. If you are not seeing the small and big squares correctly, see the ophthalmologist. For at least for that purpose, from tomorrow you can see the ECGs. So, check your eyesight. So, you must have a good eyesight to look at the small squares and the big squares. Right, this is what I told you. Each one of my small square horizontally represent 0.04 second. Horizontally I told you time. Time is in seconds. So, each one of my small square horizontally is 0.04 second. So, what is the duration of my big square? 0.2 seconds. So, 5 into 0.04 is 0.2. So, duration of my big square is 0.2, duration of my small square is 0.04 when the ECG is recorded at 25 millimeters per second speed at 1 millivolt standardization. Vertically, each one of my small square is 1 millimeter, each big square is 5 millimeters. Vertically, I am measuring amplitude means in millimeters. So, amplitude is measured in millimeter. One small square is 1 millimeter, one big square is 5 millimeters. So, clear? 0.4 and 0.2. 1 and 5. This is the measurement. Now, we are going to measure each one of this. I know now how to measure the amplitude, how to measure the duration. So, each one of the waves I am going to see what is the normal amplitude and duration. When it is abnormal, how it is normal. So, any ECG recording like this, you must see that in the bottom you would have had this vertical bar saying that 1 millivolt standardization or 10 millimeters per millivolt and the speed of recording is 25 millimeters per second. Without making sure this point, you are not supposed to interpret and diagnose ventricular enlargements, the bundle branch blocks and duration and so on. Now we are going to measure each one of my waveforms and say whether it is normal or abnormal. So first we are going to measure the P wave. P wave represents biatrial depolarization. It is not as if right atrial depolarization, it is a biatrial depolarization. The P wave best measured in lead 2 and V1. The P waves are best measured in natural, isn't it? My P wave direction is coming towards the lead 2, isn't it? It is a lead which is going to show me very nice P wave. That's why I am going to measure the P wave in L2. The P wave duration is measured from the beginning of the P to the end of P wave. Amplitude is measured from the baseline to the peak of the P wave. Very simple. Beginning to the end is the duration. Base to the apex is the amplitude. Right? For each one of the waves, you have to remember a particular number. Each one of the waves. P wave, you have to remember 2.5. P wave, you have to remember 2.5. So in lead 2, the P wave will be looking like this, and in lead V1, it will be biphasic. Initial positive component and terminal negative. I'll tell you why this is when you come to the chamber enlargement. But just remember the P wave looks like this in L2. So you measure the amplitude and duration in lead 2. So the amplitude should not exceed 2.5 millimeters and the duration should not exceed 2.5 small squares horizontally, which means 0.1 or 0.12 second. So horizontally it should not exceed 2.5 squares. Vertically it should not exceed 2.5 squares. Simple. If it exceeds 2.5 squares vertically, it is called tall P wave. If it exceeds 2.5 squares horizontally, it is called wide P wave. So duration increase wide, amplitude increase tall. Right atrial enlargement, tall P wave. Left atrial enlargement, wide P wave. That's all. Whenever the P wave exceeds 2.5 vertically, it is a right atrial enlargement. Whenever the P wave exceeds 2.5 small squares horizontally, it is a left atrial enlargement. When the P wave is tall and wide, biatrial enlargement. You see, ECG is so simple. Tall P wave, wide P wave, tall and wide P wave. So this is where the P wave ends. 2.5 you have to remember. The lead you must see is L2. Tall P wave is right atrial enlargement. Wide P wave is left atrial enlargement. So as I can see it here, the right atrial enlargement produces a tall P wave, left atrial enlargement produces wide P wave. So ECG of a tall P wave, as you can see it here in L2, the P wave is around 4 millimeters in height, so it's a right atrial enlargement. Here you can see it's a wide P wave, the amplitude, the duration is 4 squares, so it's a wide P wave, so this is a left atrial enlargement. Then we look at the PR interval. As I told you, PR interval, main contributor to the PR interval is AV nodal delay. Although the PR interval represents the entire atrioventricular conduction, but primarily it is AV nodal delay. PR interval is once again measured in lead 2 because you are nicely seeing the QRS, you are nicely seeing the P wave in L2. That's why PR interval is measured in L2. So it is measured from the beginning of the P wave to the beginning of the QRS complex, or from the peak of the P wave to the peak of the QRS complex. There are two ways by which we can measure. If you are not able to see the beginning of the P wave and the QRS complex nicely, you can take from the peak of the P wave to the peak of the QRS. If you are seeing the beginning nicely, you can take it from the beginning to the beginning of QRS, beginning of the P to the beginning of the QRS. For PR interval, the number to be remembered is 12 and 21. P wave what number? 2.5. So PR interval 12 and 21. 12 reversal is 21, isn't it? The PR interval should not be less than 0.12 second and should not exceed 0.21 second. Right? So the PR interval, as I told you, the PR interval, entire atrioventricular conduction by contributor is the AV nodal delay. So 0.12 to 0.21 second is normal. If it is less than 0.12 second, what does it mean? But that means my AV node is not giving delay, isn't it? My PR interval is short. My PR interval main contributor is AV nodal delay. That doesn't mean my PR interval is very short. The P wave is immediately followed by the QRS complex. That means my AV node is not giving delay. Why it is not giving delay? It is bypassed. It is bypassed by another pathway which is called accessory pathway. Sometimes in addition to AV node, you have some accessory pathways which are connecting atrium to the ventricle. So the impulse, since it is coming through the AV node, when it goes through that accessory pathway, the accessory pathway will not give any delay. So the entire P wave will be immediately transferred to the ventricle. So we will have a short PR interval. So whenever you have a short PR interval, you know the AV node is bypassed. AV node is bypassed by an accessory pathway. Suspect pre-excitation syndrome. The commonest pre-excitation syndrome is Wolff-Parkinson-White syndrome. If the PR interval is long, more than 0.21 second, what does it mean? My AV node is giving excessive delay. It is conducting with a very slow conduction through the AV node. First degree atrioventricular block, first degree heart block is the diagnosis. So PR interval is short, PR interval is long. What is the conditions? As you can see it here, the P wave is sitting on the QRS. As you can see it here, the P wave is coming just preceding the QRS complex with no PR interval at all. So this is a pre-excitation syndrome. Whereas here, as you can see, the PR interval from the beginning to the end, almost 7 or 8 squares here, 0.32 seconds PR interval. So it is a first degree atrioventricular block. PR interval is long, PR interval is short. Then we come to the QRS duration. Ventricular depolarization. QRS represent once again biventricular depolarization. The QRS is usually measured either from L2 or lead V5 or V6, because as I told you, the impulse will be coming left and inferior. So your L2 will show a nice QRS complex. Your V5 V6, because the impulse is coming towards the left ventricle, your V5 V6 QRS complex will be very good amplitude. So you can see that there. So V5 V6 or L2. The QRS duration is measured from the beginning of the Q to the end of S wave if it is present, or the end of R wave if the S wave is not present. Many times what we do is, we do not include the S wave in the calculation of duration. We measure from the beginning to the end of R wave. If the S wave is present, that also should be included. If second R wave is present, R dash, I told you, in certain situation R dash, if the R dash is present, that also should be included in the QRS duration measurement. So beginning of the QRS to the end of S wave is the QRS duration. From the baseline to the peak of the QRS is the amplitude measurement. So for QRS, you have to remember the number of 0.08 second. 0.08 second is the normal duration of QRS. So as you can see that, you have millions of cardiomyocytes which are depolarized within 0.08 second. That's it, because your Purkinje fibers are conducting impulse at the speed of 4000 millimeters per second. They are depolarizing entire myocardial cells within 0.08 seconds. So whenever my QRS duration is wide, my QRS duration is 0.16 seconds. What does it mean? What does it mean? My QRS is wide, big. That means my entire heart is not depolarized by specialized conduction system, isn't it? That means one portion of my heart muscle is getting a slow conduction. If my specialized conduction system is blocked, one portion of my heart has to be depolarized through the muscle, not by the Purkinje fibers, bundle branch blocks. So whenever the QRS complex is wide, the condition you must always think will be bundle branch block, because either a right bundle branch block or left bundle branch block, either a right ventricle or left ventricle has to be depolarized through the muscle, because for that particular ventricle, that specialized conduction system is not working. So it has to go through the non-specialized system, which is conducting at the speed of 400 millimeters per second. So QRS gets widened. So QRS is widened, bundle branch block. QRS amplitude less than 26 millimeter is normal. If it is more than 26 millimeter in V5, V6, indicate ventricular enlargement. Ventricular, the heart has become larger, either it's hypertrophy or dilated. The amplitude of the QRS is abnormal. So the QRS normal amplitude can be abnormal in enlargement. QRS duration can be abnormal in bundle branch block. It can be wide, it can be tall. Tall is ventricular enlargement, width is bundle branch block. That is QRS. The number to be remembered for QRS is 0.08 second. Right. Now you can look at this here, the ECG here. See the QRS duration, QRS amplitude here, 1, 2, 3, 4, 5, 6, 7 or 8, 40 millimeters. What does it mean? 26, exceed 26 millimeters, it is abnormal. So this in the ECG tells you it's a ventricular enlargement is there. Whereas see the QRS duration here. What is the duration of QRS here? 1 big square. 1 big square means what is the duration? 0.2 seconds. What is the normal duration is 0.08. Here the QRS is wide. What diagnosis this is? Bundle branch block. So now we have seen P wave, PR interval, QRS. Now the ST segment. I told you the most crucial segment in all the ECG is ST segment. So this is the ST segment, is the interval between the end of depolarization to the beginning of repolarization. The most important and the most crucial segment in the ECG does not have measurement. That does not have any measurement. It should not be depressed, it should not be elevated. That's all. The ST should not be depressed, ST should not be elevated. There is not no specific numbers for ST segment at all. If the ST segment is depressed or elevated, it is acute coronary syndrome. So that's why we told you ST segment is a widow making segment. If you do not manage ST segments properly, you will create lot of widows. So that's why it is called widow making segment, because all acute coronary syndromes are going to be manifested by the change in the ST segment. The most important segment, no specific measure, it gently merges with the T wave. As you can see it here, the ST is, you can see that here this is a baseline. What's happening to the ST segment? Significantly depressed. Acute chest pain with the ST segment depression, or acute chest pain, what's happening to the ST segment here? Elevated. Both are crucial conditions, acute coronary syndromes, unstable angina and ST elevation MI. So we'll tell you something about that tomorrow. All these things will be told in coronary heart disease about the ST segment and so on. Now we come to the T wave. T wave goes in direction and amplitude with the QRS. It goes in direction and amplitude with the QRS. That means direction is with the QRS. It's upright QRS, upright T wave. Negative QRS, negative T wave. QRS is tall, T wave is tall. QRS is small, T wave is small. Because it's logical. Whatever gets depolarized has to be repolarized. So if a depolarization is bigger, repolarization is going to be bigger. Depolarization is smaller, your repolarization has to be smaller. Whenever your T wave exceeds these 2 points, or it is not satisfying these 2 points, either it is not going in direction with the QRS, or the amplitude is bigger than the QRS or the smaller than the QRS, it is abnormal. So the T wave represents ventricular repolarization. Whenever the QRS is upright, it is upright. It is measured in V2 and V3. Where the T wave is nicely seen, you have to measure the amplitude. There is no duration of the T wave. It is only the amplitude from the baseline to the peak of the T wave is the amplitude of the T wave. So T wave goes with the QRS in amplitude and direction. This is what I told you. The normal T wave should not be more than 40% of the succeeding or the preceding R wave. It should not be more than 40% of the QRS. So it goes with the QRS. So first measure the QRS amplitude. 10 millimeter QRS. The T wave should not exceed 4 millimeters. 40% of the QRS. If it exceeds 40%, you call them as a tall T wave. If the QRS is 10, the T wave is 9, it is tall T wave. And it should be at least 20% of the previous QRS. So if it is 10 millimeter QRS, your T wave should be at least 2 millimeters. It is less than 2 millimeters, it is a low voltage T wave. If it is more than 4 millimeters, it is high voltage. So remember 40 and 20 for the T wave. Remember two conditions for tall T wave, two conditions for a low voltage T wave. Two conditions for tall T wave is ischemia and hyperkalemia. Two conditions for a low voltage T wave is hypokalemia and a non-specific change. It could be still a many of our patients may have normally low voltage T wave. So it may be a non-specific change or a hypokalemia. So this ECG you have seen or not seen? This ECG you have seen? Yes, this is one of the MCQs we told you whether the T wave direction is normal or abnormal. Here the T wave is abnormal because the direction. QRS is upright, but the T wave is negative. That's why here the T wave is abnormal because of the direction. See it here, the T wave. What's happening to the T wave? See, so big. So I told you two conditions which can produce tall T wave. One is ischemia, another is. So the differentiating point is look at the contour of the tall T wave. If the T wave has got broad base and a blunt apex, relatively blunt apex, broad base, blunt apex, it is ischemia. Broad base, blunt apex is ischemia. Whereas look at this T wave. What's happening to the T wave? See the base, it's so narrow. See the apex, it's arrowhead apex, so narrow and sharp. So whenever the tall T wave has got a narrow base with a very sharp apex, it is hyperkalemia. So this is hyperkalemia. You can see that very short. You compare the previous ECG here. See the base, see the apex, see the base here, see the apex. So nicely you can see once you look at this T wave, you know it is hyperkalemia. So look at the contour. Whenever tall T wave, broad base blunt apex is ischemia, narrow base sharp apex is hyperkalemia. Two conditions which can produce the tall T waves. Whereas the low voltage T wave will be less than 20% of the preceding R wave. Then after the T wave, you may have a very small wave which is called U wave, which is due to the repolarization of the Purkinje fibers. Once again, this U wave you have to see in lead V2 or V3. Sometimes you may see, sometimes you may not see. Just like I told you about the T wave, which will go in direction and amplitude with the QRS complex, the U wave will go in direction and amplitude with the T wave. If the T wave is tall, U wave is tall. T wave is upright, U wave is upright. So whenever you have a low voltage T wave, but a prominent U wave, whenever you have a low voltage T wave, expect the U wave to be small. But you have a low voltage T wave, but a prominent U wave. That's a condition of hypokalemia. That is a condition of hypokalemia. Whenever you have upright T wave, but the U wave is inverted, it is ischemia. Right? Just like our T wave. So that U wave will go in direction and amplitude with the, first remember, one of the important conditions which can produce abnormal U wave will be a hypokalemia. Hypokalemia will also produce the low voltage T wave. So that is the U wave. Inverted U waves is coronary heart disease. Then when you measure the QRS, you measure the depolarization. When you measure the T wave, you measure the repolarization. In QT interval, I am measuring both from the beginning of depolarization to the end of, so entire depolarization, my distance between depolarization and repolarization of ST segment, then also the whole of repolarization. So the QT interval is usually measured in lead AVL. QT interval is measured in lead AVL. So lead AVL, you have to measure the QT interval from the beginning of the QRS complex to the end of the T wave is my QT interval. This is my QT interval. So the QT interval represents the combination of entire depolarization and repolarization. So the QT interval will vary with the heart rate. Bradycardia will produce a long QT, tachycardia will produce a short QT. That's why whenever you measure a QT interval, you have to correct it with the heart rate. By Besset's formula, many of your ECG books will give you tabular columns by which you can just see the heart rate and see what is the expected QT interval for that heart rate. So your measured QT interval is longer than that particular measured given interval. It is long. It is short also. You can diagnose from the QT interval. So bradycardia long QT, tachycardia short QT. The importance of QT interval is whenever a young person, child coming with syncopal attacks and also fits, don't always think it is an epilepsy. Many times it may be due to long QT syndromes which is producing a dangerous recurrent ventricular arrhythmias and producing a Stokes syndrome attacks which will be the cause of syncope and fits in children. Children and young adults, you must always, whenever there is a fits and syncope, look at the QT interval. Whether the QT interval is long, whether it is producing a dangerous arrhythmia. Many times, majority of these long QT syndromes are treated as epilepsy without looking at the ECG and looking at the QT interval. So always remember that. In adults, once again, whenever there is a syncope, whenever there is a recurrent syncopal attacks or fits, in addition to our mindset is to look for a bradycardia. Whenever there is a fits, we always look at the bradycardia. When the heart rate is normal, we think that the syncope is not cardiac. But the patient may have a normal heart rate, but if they have a prolonged QT, still they can have syncopes and recurrent dangerous ventricular arrhythmias. So any syncope and fits, look at the QT interval. The short QT interval can be produced by digoxin and hypercalcemia. The only drug which can produce a short QT interval is digoxin. Digoxin is the one which, so all the other intervals for digoxin are increased. The only interval which is shortened by digoxin is QT interval. So QT interval is shortened by digoxin and hypercalcemia. Always see QT interval when the patient comes with a syncope. So this is the importance of QT interval. So you can see the 4-year-old girl coming with seizures. You can see the QRS is here. Next QRS is here. Your T wave is going 3/4 of the RR interval. It is going well away from almost to the next QRS. your QT interval is going. So simple ECG like this will tell you a very valuable clue of the reason for syncope and seizures. Is that clear? So P wave, what is the number? 2.5. PR interval, what is the number? 12 and 21. QRS, what is the number? Not 8. ST segment, what is the number? No number. Right. T wave, what is the number? 20 and 40%. QT interval, normal QT interval, I tell you, it's 0.44. QT interval, normal QT interval is 0.4. That means 11 small squares horizontally. 0.44 is normal QT interval. Right. So we are going to tell you one of the easiest things in cardiology or in the ECG is heart rate calculation. Apart from looking at the small squares and big square after checking your eyesight, the next thing you can do will be always a heart rate calculation, which is the easiest thing in the ECG. So now we are going to calculate the heart rate. So once again, we must have some rules before we calculate the heart rate. Once again, make sure the speed of recording is what? 25 millimeter per hour per second. So 25 millimeter per second is the normal speed of recording. Make sure 1 millivolt standardization recording. In normal ECG, all your P waves should be followed by the QRS complex. So you need not separately calculate the heart rate for the atrium and heart rate for the ventricle. So once you calculate the ventricular rate, it should be the atrial rate also in a normal sinus rhythm. So calculate the ventricular rate only when there is a normal sinus rhythm. Take lead in which the QRS is seen nicely. So don't take a lead in which you have to see the QRS with a binocular or a lens or a microscope. So in 12 leads, in which lead you are seeing either the QRS may be tall, QRS may be upright, QRS may be negative, doesn't matter, but nicely seen QRS. So you have to select a lead in which the QRS is seen nicely. Then select two adjacent QRS complex in the same lead. Don't take one QRS complex in lead AVR, another QRS complex in lead AVL and calculate heart rate. When you take two QRS complex, will be the same lead AVR or same lead AVL or L2. Two adjacent QRS complexes in the same lead. In which lead you are seeing the QRS complex nicely. The speed of recording should be 25 millimeters per second. So these are the rules to calculate the heart rate. So then the heart rate calculation depends upon whether your eyesight is good or whether you are studious. So your eyesight is not good, you are little lazy. What you do is take the number of big squares between two adjacent QRS complexes. So you have selected two QRS complexes, isn't it? Take how many big squares are there in between these two adjacent QRS complexes, and 300 divided by number of big squares in between two adjacent QRS complexes will give you heart rate per minute. When your eyesight is not good, you are not able to see the small squares, you can just take big squares, how many big squares are there, and 300 by big squares will give you heart rate per minute. But you are very studious, your eyesight is so good, you can see the small squares even a very big distance. Take the number of small squares in between two adjacent QRS complexes. 1500 divided by, so because 5 squares contribute, 5 small squares contribute 1 big squares. So when you are taking the small square, it is 300 into 5. 1500 divided by number of small squares in between two adjacent QRS complexes will give you the heart rate per minute. The important caveat is this you must apply only for the regular rhythm, not for irregular rhythm. Like atrial fibrillation, you should not apply this rule. Only when the atrial rhythm is normal, all your P waves are followed by QRS complexes, patient is in sinus rhythm, then only you apply this rule for calculation of heart rate. Is that clear? So two adjacent QRS complexes in the same lead in which you are seeing the QRS complexes nicely when the ECG is recorded at 25 millimeters per second speed. So these are the caveats. So normal heart rate is 60 to 100 per minute. Below 60 is bradycardia. Above 100 is tachycardia for regular rhythm only. So this is how we calculate the heart rate. Now you can see that here. We can see first make sure the speed of recording 25 millimeters per second. Then you can take either even L2. Although the QRS complex is negative, your very big QRS complexes are there. Take two adjacent QRS complexes in the same lead, for example L2. So count number of big squares 1, 2, 3 and 4. So number of big squares in between two adjacent QRS complexes is 4. What is the heart rate? 75. But the machine is giving 78 per minute, isn't it? See that? The machine is giving, why it is giving 78? It is smarter. So it is counting small squares. So when you count small squares, you will be more specific. not 65, not 60. When you big squares, it will be 60, 75, 100, 150, only that. But 78, 89 when you count the small squares. So always try to count, keep your eyesight good and try to count your small squares between two adjacent QRS complexes. This way how you calculate the heart rate.